तो फरहान मिर्जा, शायद आप लोगों से कुछ से मुलाकात हुई है पहले. I work at the University of Kentucky, which is in Lexington, Kentucky, in the United States. I'm an associate professor here. I do epilepsy surgery and neuro-oncology and skull. The goal of this talk is really to just understand what are vestibular schwannomas or also known as neuromas, और हम बेहतर कैसे, how can we treat these to the best of our abilities. So a little bit about our team. So the North American Skull-Based Society, it gives these multidisciplinary teams of distinction labels to programs if they have a representation from multiple specialties. As you can see, we have a wide array of specialists who participate in our skull-based endeavors, and this is our skull-based team at the University of Kentucky. So it comprises of specialists from otolaryngology, from radiology, pathology, ophthalmology, and neurosurgery. So it truly is a team effort. This is the lateral skull-based team. So we have an anterior team which deals largely with endonasal endoscopic techniques through the nose, anterior skull-based pathologies, mostly pituitaries and CSF leaks. The lateral skull-based team deals with more acoustic neuromas, middle fossa. I'm sorry, I never enlarged my screen. Can you see my screen properly? Full screen now?
Yes, sir.
Okay. The lateral skull-based team, and these are ideas that you all should be thinking about too. This takes care of pathologies of the lateral skull base, such as middle fossa, tumors, CSF leaks, acoustic neuromas, benign issues such as infections of the temporal bone, etc. So what is a vestibular schwannoma? So it's a benign tumor that arises from Schwann cells around the vestibular component of the eighth nerve. And some of you might remember from your pathology books that it's called the Obersteiner-Ridlich zone, which is that transition zone where central myelin transitions over to peripheral myelin, or in other words, oligodendrocytes are taken over by Schwann cells in the peripheral myelin, and this is thought to be the origin. Is it truly the origin? Hard to say, but this is thought to be the origin of these. What is the anatomic location? These are located in the cerebellopontine angle. So a lot of times you'll hear people say CP angle lesion, CP angle lesion. That's just a blanket term for any lesion, any mass, any problem that sits in the cerebellopontine angle. This is a triangular space in the posterior cranial fossa, which is surrounded by the cerebellum posteriorly, pons medially, and the petrous temporal bone laterally. I want to keep this session interactive, so please stop me, ask questions, feel free to interrupt if something doesn't make sense. The CP angle, or the cerebellopontine angle, is a busy place, and some of you have had the chance to be in that space or participate in an operation where you're working inside that space, and you know that there are lots of important neurovascular structures, veins, arteries, nerves, several important cranial nerves. This is a Roten depiction, cadaveric depiction, injected cadaver head, which shows, again, the busyness of this whole region. This picture to the bottom right is a nice depiction of cranial nerve 8 as it exits the posterior fossa and enters into the internal auditory canal. And as you can see, the dura covers that portion of the nerve as it travels out into the petrous bone and then continues on into the middle ear, etc. So these are slow and benign tumors, and almost all patients have a normal life expectancy even after that. So how do these present? Hearing loss is the most common presenting symptom, but often patients will have tinnitus, vertigo, imbalance, and sometimes severe headaches presenting with hydrocephalus, but that is usually in the case of very large tumors with significant brainstem compression. A red flag in these situations, if a patient presents to you with some of these symptoms, but also has facial weakness and or numbness, you should be thinking of something other than a vestibular schwannoma. So the difference between what I would think in practice in the United States and the United Kingdom versus Pakistan would be that a lot of patients, when they present to us, they're already presenting with a complete workup by ENT for hearing loss, tinnitus, and they have had an MRI scan which clearly shows the problem. But I suspect that in a setting like Pakistan, sometimes patients may not be presenting with imaging or may be presenting with suboptimal imaging. So a conglomeration of these symptoms should lead you to think, okay, something is happening in the middle ear space or the posterior space that could be leading to these issues. So it's not just vestibular schwannomas that present like this, any other problem relating to the posterior fossa, cerebellum, middle ear, petrous bone, all of those can present. Diagnosis is simple audiogram to understand the extent of the hearing loss and to determine type. Before an audiogram, your clinical exam, your tuning fork exam will also help you understand the type of hearing loss. And then obviously some sort of brain imaging will help you go down the path of whether it's a lesion or it's something else. Treatment options are rather simple and straightforward in terms of what choices you have. So in some instances, observation and serial imaging is appropriate. In some situations, radiosurgery is appropriate. And in some situations, surgical resection, and there you have different ways to approach tumor surgery. And really, it's about individualized care for each patient. And a lot of times, the decision on what to do, which approach to take, which treatment method to use is based on the patient's overall health, their age, the size and growth rate of the tumor, how severe are the symptoms, and in some cases, what does the patient prefer? So when we're thinking of vestibular schwannomas, radiographically, you'll find multiple classifications. This is the one that I find simple and quite useful. It is the Coos grading system, which takes into account the size of the tumor and its relation to the brainstem itself. Coos grade 1 is when you have a tumor that sits within the internal auditory canal. Coos grade 2, when you have the tumor in the internal canal, but it's now peeking out into the cerebellopontine angle. Coos grade 3 is when the tumor is out in the CP angle and it's abutting the cerebellar trunk or the middle cerebral peduncle or the brain stem, but it's not displacing or pushing into. And Coos grade 4 is something that is more than that, that's pushing or displacing the. So with that sort of basic summary about vestibular schwannomas, before we move on to some cases, interactive cases, any questions? And please feel free to speak up if you have any thoughts, questions.
Lee, do you have any queries?
All right, so who's going to take case number 1?
Eamon. So Eamon is our resident. She's a junior resident in our program, and she'll be taking the first case.
Excellent. Eamon, which year resident are you?
I'm a year resident at the neurosurgery program at AKU.
Right, which year?
Overall, year 3.
Year 3, excellent. Have you seen acoustics or vestibular schwannoma?
I'm sorry.
Have you seen patients with vestibular schwannomas or acoustic
Yes, sir.
neuromas?
Yes, sir.
Yes, excellent. All right, so here's your first case. This is an 82-year-old gentleman. Um, he he had some occasional dizziness, no hearing loss, but just kind of felt dizzy all the time. So he went to his doctor and they said, "Oh, well, you have AFib, you're on Eliquis, but I'm concerned we should make sure you don't have a bleed in your head, being on Eliquis, which is a blood thinner, right?" So they scan his head and they find this lesion in the posterior fossa. Okay, so now he's in your clinic and he wants to know what would you like to do with him.
Okay.
So just let's start. So imagine that I'm that 82-year-old patient. I'm in your clinic. What would you like to ask me within like 1 minute? And then what sort of tests what sort of diagnostic tests you want to see?
Okay. At first, obviously, I'll start with the general physical examination, the function, what the functional class of the patient is. Once I've assessed that, what symptoms he's been experiencing. Is there any vestibular symptoms? He has no hearing loss as written here. Has he had any symptoms, vestibular symptoms to name? Then, other than that, are there any? I'd like to conduct a neurological exam assessing all the cranial nerves, whether there's any deficit on that or not. Once we have that sorted, so if there like it's documented that there is a post was a lesion, so I believe that we already have an imaging in place. uh, so I'll see what the size of the lesion is.
डॉक्टर
uh,
साहब कान में दर्द बहुत ज्यादा होता है.
G.
डॉक्टर साहब कान में दर्द बहुत होता है.
Okay, so I could like have a proper ENT evaluation for that, for any middle infection or not, or to rule out any otitis media, because that could lead to these symptoms as well.
डॉक्टर साहब मुझे समझ नहीं आई आपने क्या कहा है. ओटाइटिस मीडिया क्या होता
Sorry.
है?
uh okay, but okay, if he's already experiencing discomfort ear में, so that could be a middle ear infection as well. So I'd
Yeah,
like an ENT
all I'm
evaluation.
doing is I'm pretending to be the patient and trying
Yeah.
to just take you down the wrong direction. Okay.
Okay.
Anyhow, so you have you've done your assessment, you've done your physical exam, and you find that there is some decreased hearing on the left side as well. ठीक आपने tuning fork exam किया and you find there's some decreased hearing on this.
Mm-hmm.
We move on और imaging पे आपको ये नजर आ रहा है. Remember, I'm 82 years old. I have AFib. I'm pretty healthy, but I have AFib. Recently, Eliquis पे start किया है, cardiology भी किया है, and now I have this. And my main issue is dizziness. Really, that's really it. No other problems.
Okay.
What how would you how would you describe this to me? What is this, and what would you tell me should be the next step?
Okay. It is I can see an extra axial contrast enhancing lesion. These are post contrast axial coronal and sagittal images showing an extra axial contrast, avidly contrast enhancing lesion at the left CP angle. That is not displaced. That is like pressing onto the brainstem, but it's not displacing it. So if it's this small and it's not actively causing any symptoms, if it's asymptomatic, we can watch. We can just do. And since the patient is also not a surgical candidate, we can just observe these lesions. But if at any point then if it tends to become symptomatic, then we might have to proceed with any with sort of intervention. Considering he's not a surgical candidate, um, for a lesion this small, SRS could be an option as well, provided that it's like less than 3 centimeter in size. I'm not.
Okay, so and these are your options. So
Yeah.
as you mentioned, observation and serial imaging is an option, radiosurgery is an option, and
Yeah.
surgical resection. In an 82-year-old who this is his first time being imaged, first image that you found, there's this lesion. You have no proof that it is growing or not, and he's not very symptomatic, right? And he has comorbidities. So the best option in this situation would be to observe him, maybe get another image in 6 months to a year. And if there is no serial growth on that, then you can say we don't really need to treat you, we'll just keep watching. Obviously, if symptoms change, if symptoms worsen, then with his age, I think again, radiosurgery would be a reasonable option. Okay? Surgical resection in an old patient like this with comorbidity, with a small tumor, is really not of much benefit. Rather, you'll harm the patient more. Achha, I just want to make sure. Can you guys hear me okay? Because I saw in the chat there was some issue with audio.
It's slightly at the lower end, sir, but we'd like if you could just could be slightly closer to the mic. But it's better now.
I'm just a very quiet person, so I don't speak very loudly. Anyhow, we'll keep. Is it better now?
Yes, it's better now.
It's better now. ठीक है,
Thank
चल,
you.
very good. All right, so we will keep going. So, Eamon, you decided to observe, and you'll see this patient back in your clinic in 6 months or a year. Who's going to take the next case?
Sir, Malaika is another one of our junior residents, can take it.
Okay,
Dr. Malaika.
Malaika. So here you have a 35-year-old male. So let's say I'm the 35-year-old male, I'm healthy, and I can't hear out of my left ear at all.
Okay, so first of all, so this is a 35-year-old male. Okay, so first of all, are there any, I'm gonna ask about the rest of the history. Are there any balance difficulties or signs of raised ICP, for example, headache, vomitings? No.
No, I just
Okay,
can't
no.
hear, and I noticed that I can't hear for the last several months, and everything just sounds muffled on this side. मैं फोन पे बात करता हूँ तो things don't make sense in my left ear, तो मुझे सीधे हाथ पे रखना पड़ता है फोन. It's just hearing, और कोई मसला नहीं.
Okay, was there any recent history of trauma or infection?
No.
No. Okay. So you said is there any associated tinnitus or ringing in ears? Like we'll just look for all the symptoms related to the ears. Nothing.
Some ringing, but nothing that bothers me.
Okay. So then we'll examine the patient, and then we'll go for investigations. So
examination पे क्या expect कर रहे हैं आप? क्या मिलेगा?
So in this case, we should have a sensory neural hearing loss. Since we are talking about vestibular schwannoma and everything, should have a sensory neural hearing loss.
Okay.
So we'll have the Rene's and Weber's test, and we might as well send the patient to the ENT, get a ENT review or get the auditory testing done.
डॉक्टर मेरा ENT वालों ने टेस्ट किया था, उन्होंने कहा कि I have less than 50% serviceable hearing. इसका क्या मतलब है?
आपका इसका मतलब so this means कि आपका जो कान के hearing है वो almost 50% आधे से ज्यादा जा चुकी है इस वक्त. तो उसके लिए हमें देखना पड़ेगा कि क्यों आहिस्ता आहिस्ता ये जा रही है. पिछले हम कितने अरसे में हुआ है? सॉरी, हाउ मच?
2 साल से चल रहा है.
हाँ, सो ये प्रोग्रेसिवली जा रही है, तो हमें इसके लिए फिर अब वर्कअप करवाना पड़ेगा, यानी कि हमें देखना पड़ेगा कि क्यों हो रहा है.
So remember the reason I mentioned the 50% serviceable hearing. That's an important distinguishing point on how you treat these patients, right?
Okay.
Yeah. Well, let's move
Can I
on.
ask something here? I'm sorry. This is Umar.
Assalamu alaikum.
Walaikum assalam. So,
Assalamu alaikum, sir.
Walaikum assalam. I wanted to ask, आप में से कौन, I mean, who still does this Rene and Weber's tests?
Sorry?
ये जो Weber's test आपने बताया, tuning fork test, you guys do it?
So, we don't usually, but ideally we should. I think so.
Yeah, I don't think anybody does those
Okay.
anymore. So I just wanted to make sure. I mean, these are nice
Okay,
to
we
know.
don't. Hmm.
But the pure tone audiogram, the PTA जिसको कहते हैं जो Dr.
Audio.
Farhan is alluding to, this is the language you guys need to understand and you need to be talking about. Okay, continue. Sorry.
Is that the language you use in locally, Dr. Inam? Pure tone audiogram ही कहते हैं
Yeah.
उसे या कुछ और?
Yes, that's what we
Pure
do.
tone.
And both Ayman is right and so is Umar. The problem over here is there is a bunch of professors and doctors who are teaching wrong things. कि वो माइलोमेनिंगोसील को आपने एक्सरे फोल्ड करके उसमें से देखना है कि ट्रांसलूसेंसी आ रही कि नहीं आ रही है और now they're talking very weird kind of things. I don't know where it's infiltrating from. It's a constant struggle to fight against those people. But thank you for bringing this up, Umar, because those are things that we need to try to do things with whatever international practice is instead of finding our own ways.
All right, so this is the imaging. So do you want to comment on this?
So we can see MRI brain, axial, sagittal, and coronal sections, and we can see a left extra axial contrast enhancing lesion in the cerebropontine angle, and there is no associated hydrocephalus currently.
Good.
However, there is a mass. It looks like a mass effect on the brainstem.
Is it true mass effect or is it simply just sitting against the brainstem?
Just like it's just slightly pushing it. It's not significant.
Okay.
As far as I can see.
All right, so now you have a healthy 35-year-old whose only symptom is hearing loss for 2 years. And picture that this patient got. And now he's all concerned. Okay, I have a tumor and I want you to take it out.
Okay. So since his hearing has been 50% of his hearing has been affected, I would like to go for a surgical resection as it has better chance of preserving the hearing.
Why do you say that? Better chance of preserving hearing when you already have less than 50% serviceable hearing on pure tone audiogram?
Not sure.
So by definition, if you have less than 50% serviceable hearing on your pure tone audiogram, the chance of improving that is next to impossible. So really at this point, the discussion, and these are real case scenarios. So the discussion we had with this patient was that you're young, the chance of this growing is reasonably high, but this is the first time we've ever imaged this. He's bothered by his hearing loss, but he's functioning really well. So our recommendation to him was, let's observe, let's get another image, and let's follow and see how this tumor grows. But there's no right or wrong answer. You can recommend radiosurgery. So there is good literature to suggest that patients that you're worried about who may not follow up regularly, upfront radiosurgery can actually reduce long-term growth rates and prevent major growth in these tumors. So observation, serial imaging, radiosurgery, good option. Surgical resection is absolutely on the table for this patient, if that is what they're leaning towards. But when you see a patient for the first time with one image, don't jump into surgical resection. 6 months, 1 year, follow them a little bit, see the growth of the tumor, see the progression of their symptoms, and then decide. And this is exactly what we decided. He hasn't had his first, he hasn't had his second imaging yet. So we're observing this patient. The difference between these cases, case 1 and case 2, case 1 is purely you want to observe and only treat if there's growth or if there's worsening symptoms because you have an older gentleman with comorbidities. This is a young man, 35-year-old, long life ahead of him. Very likely that the tumor will grow. Starting point, a cautious starting point would be with serial imaging, with a low to proceed with surgical resection. And radiosurgery is an option if the patient is averse to the idea of surgery. Okay.
Sir, I'm sorry
right.
to cut you off here. Sir,
Yes.
basically, could you just revise this for us, for our residents and as well as the medical students? What exactly would be the cutoff points in, small lesions where we would proceed for surgery, we would proceed for radiosurgery, we would proceed for observation itself? Because that becomes quite confusing for a lot of people. So if you could just revise that small criteria, if I think we do have a bit of
We
time.
will come to that towards the end of the presentation. As we go through these cases, then towards the end, we'll discuss. So following strict criteria is not the idea of this. I won't give you if 3 centimeter tumor पे आपने क्या करना है, 5 centimeter tumor पे क्या करना है. This is where the individualized, nuanced approach to each of these patients comes. If you're just going to follow an algorithm, then I think you've not really understood the point of how to treat these patients. Okay.
I think that's a very important point. Everybody needs to understand what Dr. Farhan is saying. It's a multifactorial decision. We're not just following an algorithm, a simple algorithm. तो खैर फिर भी होगा ही वो, when you have all those factors, but not a simple algorithm.
डॉक्टर चौहान के पास अक्सर एल्गोरिथम्स होते हैं, तो डॉक्टर चौहान
लेकिन नहीं, but his algorithms are complex ones. They are not simple ones.
No, no. I think one thing to understand with acoustics is that their growth is very unpredictable. They don't have a linear growth. जिस तरह gliomas में देखते हैं ना, तो they can grow like 2 millimeter to 8 millimeters low grade gliomas per year. You can kind of predict that they will grow. Acoustics don't do that. Acoustics can remain the same size for years, and then for some reason they can just decide that they're going to grow. So just because you have, and I'm not particularly talking about this particular patient, लेकिन उसमें आप predict नहीं कर सकते कि कौन सा tumor is gonna grow in the next scan or over a certain period of time in which tumor is not going to grow. I think if you are reaching the threshold, and depending on your own personal experience and the experience of the department or group that you're working with, I think 2 to 2.5 centimeter size के बाद जो है hearing preservation is almost impossible. अगर आप 2.5 centimeter पे आ गए हैं, तो hearing preservation की बात, people usually don't talk about that. Like Dr. Mirza just said कि hearing तो उसकी चली गई है, and it's not a tumor. If you look at it, it's probably 2 centimeters. I don't know, just over 2 centimeters. So hearing की बात उस वक्त पर facial nerve की बात होती है. And so the larger the tumor is, the facial preservation is going to be an issue. So those are the kind of things that you need to start to consider and start to talk to the patient about. कि अब facial nerve हमने बचानी है, hearing तो चली गई है. So I think for this particular patient and this age, I would agree that surgery would be much better because of the size of the tumor and also the age of the patient, rather than radiosurgery, unless there are very strong preferences by the patient.
So yeah, I mean, thank you, Umar, and thank you for and just need to get an idea that this is not something exactly as Farhan and you are saying, an algorithm. So there are differences in opinion. I personally would watch this tumor and see the growth, because by some series 40-50% tumors don't grow, 5 to 6%
Exactly.
even shrink. And I typically use if it's less than 1.5 centimeter. That's when I would think about microsurgery. But if it's bigger than that, because you also have to look at the complications that can happen in the hands of a general neurosurgeon. This is what the practice over here is. So, Umar, you or Farhan, you have a very specialized training and all that thing. So I think maybe safer in your hands. But it may not be so safe in the hands of a general neurosurgeon. So वो भी मैं अपने ध्यान रखता हूँ in the perspective of giving these recommendations.
Dr.
So I
Namte,
would,
general neurosurgeon should not be doing an acoustic, number one.
but
They
but
just
but
should
the, but,
not
the,
be doing
but the,
acoustics.
unfortunately,
वो
in
सारे facial
Pakistan,
paralysis से निकलेंगे लोग फिर, if you're not doing, if a general neurosurgeon is doing it. But that's a very valid point.
yeah,
That's a very, very good point. So I just wanted to sort of clarify. I wasn't saying to jump on this patient and do surgery.
right.
जो आपने कहा है कि that I agree with you कि ये tumors इनकी growth predict नहीं कर सकते, and a lot of tumors won't grow, they sit silent, and a lot of them may actually shrink. So yes, proof of growth, just like in meningiomas. अगर meningiomas को आप बगैर proof of growth के treat करना शुरू कर दो, तो आप you won't have a lot of other stuff to do.
Right.
So you have to have proof of growth, unless the patient is presenting with a giant tumor and there's edema in the brainstem and so on and so forth. So yeah,
But
I
I mean,
agree.
at the same point, it's very important that you said about your inclination, because I totally agree with that also. So it's very dependent on, and that's the point what Farhan is trying to bring. Okay, it's not one decision, it's not one algorithm.
This is really a great discussion. I'm hoping the residents are benefiting from this. I think the most important thing with these two cases is, and this is my own rule and my ENT partner's rule, that generally with patients like this, जिनका सिर्फ एक image हुआ हुआ है, we don't jump into any kind of treatment. You want to see how this tumor is behaving. जैसे डॉक्टर नाम ने John ne kaha, you want to see how the tumor grows or doesn't. That's the most important takeaway from these first two cases. Let's move on to this case. All right, ye kaun lenge?
Sir, Dr. Daniel is our senior resident, actually, is a chief resident. So I would like to nominate him for this one.
Okay, Daniel, 25-year-old female, comes to my clinic or comes to your clinic, looks very disheveled, very tremulous. उसको कई हफ्तों से dizziness हो रही है, imbalance, falling. उसको अंदाजा नहीं है, but she's also having some right-sided hearing loss. So we've already talked about, the workup and everything that you would be thinking of. But just looking at this patient's description and hearing the first two cases, what are you thinking? What might be happening to this patient?
So if you ask me the localization of the lesion, then it would be at the CP angle area because of the right-sided hearing loss along with the history of dizziness.
The important point is the severity of symptoms, right? Compared to those other two, she just doesn't look right. This is what she has. See? What do you want to do with this patient?
Okay, so she has a right-sided huge CP angle lesion along with the ventriculomegaly and brainstem compression. So I would offer this patient the surgery along with the temporary CSF diversion in the setting.
Temporary CSF diversion. Very good. That's very important. Temporary, not put a. Excellent. अच्छा, इसमें एक important sign जो डॉक्टर नाम भी अक्सर बात करते हैं, the inverted ice cream cone. ठीक? You can see how you have the cone right here, that is the internal auditory canal, and then you have the scoop of or triple scoop of ice cream on top. See? It's a large acoustic. There's really no other treatment than actually treating with surgery. And as you mentioned,
Can I barge in? here, Farhan?
Yes.
So I would actually put a shunt in this patient as my first move. This is what I would do, and then tackle the tumor. But I just want to throw out that controversy in the middle of all of this.
But why
My
would you
first
do
move for this, my first move for this patient would be to get him out of trouble, and that is hydrocephalus. He's gonna die because of hydrocephalus, and this is a complex lesion. You may not be able to debulk him sufficiently in one go, or you may, and this may be stuck to the brainstem, and you may want to do it serially. You may want to go in and debulk some of it, let the tumor fall away from brainstem. You haven't shown us any FLAIR images to see if there is a lot of edema in the brainstem. So I would place a shunt as my first thing in him, and then get him out of trouble, and do this not as a war zone, wartime case, but as a peacetime case is how I would do it. But let's see.
That's a great point, QK, and that's a different way of approaching this. Address the problem, which is her hydrocephalus, or uske baad tackle the tumor. I think that's a very valid way to do it. We did it in a different manner. So we admitted her from the clinic, and I think we took care of her that same week. Before we go on to see what we did, so at this point you have to think of a kaun-si approach. So your chief resident, Daniel, any thoughts or do you have any ideas about different approaches to these types of tumors?
Yes, sir. The three major approaches which are defined about the CP angle tumors, and the most common approach we do for these lesions is the retrosigmoid approach, in which if there is serviceable hearing, then there is a good chance of hearing preservation. And the second approach is the translabyrinthine, in which we go through the lateral part of the internal auditory canal. And there are absolutely, I think there are no chances of the hearing preservation in this approach, because we go through the hearing apparatus of the internal auditory canal. And the middle fossa approach, as you mentioned here, that it is reserved for the small intracanaliculaar tumors, in which we have to drill the internal auditory canal.
Very good. You made an important point. Okay, the choice of approach routinely used at your institution is retrosigmoid. So that is the key point, that whichever approach you're most comfortable with for these tumors, that is the better approach. There's obviously some nuances and some discussions. Okay, retrosigmoid translabyrinthine से बेहतर है, कहाँ पे उसका अच्छा use हो सकता है. But in general, whatever your group, what you are comfortable with as the acoustic surgeon at your center, that should be your approach. Middle fossa is a completely different discussion, so we won't really talk much about that in this talk today. We'll quickly move forward क्योंकि time थोड़ा है हमारे पास. This is a view of all these different approaches. Just to give the medical students an idea, the sigmoid sinus, which runs into the transverse sinus and then into torcula and inferiorly into the internal jugular vein, that is the major landmark. The retrosigmoid is behind the sigmoid sinus. Translabyrinthine is through the mastoid bone in front of the sigmoid sinus, and middle fossa is an approach coming superiorly on the top of the internal auditory canal. Okay. Retrosigmoid, as we just talked about, okay, it's behind the sigmoid sinus, and this is the incision that I used for this patient. So we use a retrosigmoid approach. It's a large incision. This is not typical. Typically, a much smaller incision. And there are some benefits of using this incision. At least what we have found is that you're able to move all the muscular layers inferiorly, and you have a very clean corridor to work in then without any hindrance. This is the approach we used. So back to Dr. Omar Chauhan's point about putting a shunt in versus temporary CSF diversion. So as you can see, we have shaved the hair to the point we can access the occipital horn if needed during the operation. We didn't put a lumbar drain in, we did not do an EVT, and because the patient was stable. She was tremulous, she had symptoms from her hydrocephalus, but she was stable. And we used this dandy type incision. So this incision is also a dandy incision. And you can see the outlines of the transverse sinus, sigmoid, and the mastoid tip are marked out over here. So we talked about the translabyrinthine approach. So this is a depiction of that. So this, as you can see here, this is, I don't know if you can see my pointer, but you can see the transverse sinus going this way and this way, vein of Labbé, sigmoid sinus, and you're working in front of the sigmoid. This is an example of another patient who had a translabyrinthine approach. And this is the skin incision for that, which gives our ENT colleagues access to the entire mastoid. So they do the drilling for these transmastoid translabyrinthine approaches. We'll come back to this later, but let's go back to this patient. So we did a retrosigmoid approach for that patient, and we were able to remove a very large portion of the tumor. Now, the surgical nuances, we can get into some of those details, but we're very limited on time here. So we'll talk a little bit about this. The goal of these big tumor operations is to remove and debulk tumor so you can decompress the brainstem. And by that, you open up the CSF pathways so hydrocephalus resolves. But at the same time, you have to preserve the facial nerve. And if there is tumor that might be stuck to the brainstem, Dr. Chauhan alluded to that. If there's a lot of edema within the brainstem, that can indicate that the tumor is either infiltrating or it's stuck to the brainstem. So intraoperatively, what we found, the large portion of this tumor was very soft and suckable. But as you get close to the brainstem, this part was quite stuck, and then the facial nerve was not discernible. How do we find facial nerve? Facial nerve monitor. That's the only way you can understand and identify the course of the facial nerve over the tumor. You can find it at the brain stem anatomically. You can find it at the internal auditory canal anatomically. But in a large tumor like this, it is so thinned out, it's translucent, see-through, and paper thin, that the only way to really understand the course is with the facial nerve monitor. And that's what we use generally in large tumors. And the facial nerve is usually pushed anteriorly and superiorly. In this case, it was pushed inferiorly and was on the posterior aspect of the tumor. So as we identified the lower cranial nerves and we traced them back to the brain stem, we were able to find the facial all the way down there along the capsule of the tumor. The facial nerve was just translucent, paper thin. So what you're seeing on this is the outline of facial nerve with tumor left on it and brainstem with some tumor left on it. Patient had an excellent recovery, hydrocephalus symptoms resolved, face completely intact. Okay, but 3 months post-op, she's now coming back, and this is just from last week, this image. Coming back with some reorganization and maybe some increase in size of that contrast enhancing portion. Now remember, this is a 25-year-old patient with a very large tumor. She was quite symptomatic, so it must have grown at a more rapid speed than just your regular vestibular. And now, despite an aggressive resection, yes, we residual, you're now starting to see some recurrent tumor. I don't have the cut where it shows against the brainstem, there is bulk tumor that's coming back. So at this point, Daniel, what would you like to do with this patient? She was operated on in December, and this is an image from May.
So, sir, I would like to observe and rescan in 3 to 6 months probably.
Okay. So why not treat it?
Sir, because there is not a significant growth in it, and there is no symptoms of hydrocephalus, and there is no compression on the brainstem. So, rather than taking it out or referring her for SRS, I would observe her for at least 3 to 6 months and repeat MRI.
I think that's reasonable to say I will observe further. Our approach for this was that we her original tumor was large, so we know it was more aggressive than your regular vestibular schwannoma, even though it didn't have any elevated um, any indices that would indicate it's more aggressive than just your benign schwannoma. So the fact that it was showing recurrence and there's some increase in the amount of disease along the brain stem. So we thought of two options. We go in using a translabyrinthine approach because she has no hearing on this side and try to clear off the tumor completely from the internal auditory canal and from the brain stem, or just treat with radiosurgery. And so for this case, me and my ENT colleague, Dr. Cass, we decided to treat it with radiosurgery. She's on the schedule for next month, first week. So again, the point is, there's no right or wrong here. In your hands, yeah, you can say I would observe. I think that's reasonable as long as the patient will follow up. If the patient is unreliable and will be lost to follow up, you'll be looking back at a major recurrence probably within the next 1 to 2 years, right? So in the context of each individual patient, you have to make that decision with them for them. Okay. Any questions about this, Yusuf? Okay. Yusuf is on the phone. Let's go back to some of these things. So we were talking about translabyrinthine approach. When do we choose translabyrinth approach over retrosigmoid approach, right? And again, this is preference. A lot of times at our institution, if the patient comes through the ENT surgeon, and if they notice a tumor of this size, so to your right hand size, this is about 2 by 2.5 centimeter. There's not much posterior fossa extension, cerebellar compression. So they often want to do this through the translabyrinth approach, purely because in their hands they feel they can identify the facial nerve early, which is the biggest advantage of doing translabyrinthine approach, that you can identify the facial nerve early and potentially preserve facial nerve function better. Although in literature there are opposing views as well, that retrosigmoid approach gives you better facial nerve preservation. So it really depends. Again, it's a toss-up. If people are more comfortable doing the translabyrinth approach, they'll do that versus sigmoid and vice versa. We take a more nuanced approach. So the reason I have this coronal image here, if you pay attention to this part of the image, this is the jugular bulb right here. A high riding jugular bulb, in our opinion, it precludes you from being able to do a proper translabyrinthine approach. This one is perfectly reasonable, but any higher than that, then it's hard to depress the jugular bulb down, and then translabyrinthine approach becomes challenging. The other thing, you see the sigmoid sinus right here, and sigmoid sinus right here. When you're going in front of the sigmoid sinus, more often than not, you're compressing it as you're approaching the tumor. And a lot of times with translabyrinth approach, you end up with sigmoid sinus thrombus, which happened in this particular patient. So this patient who had a translabyrinth, these were her images, and she was quite symptomatic from it. She was headachy, nausea, but with hyperhydration, she got better. But that's a real problem. So we pay attention to the dominance of the sinus. So if we feel that one side or the side of the tumor the venous system is large and dominant, we avoid translabyrinth approach in those cases. But as you can see, translabyrinth is a very straightforward, clean approach. You don't have to retract the cerebellum. It's a straightforward corridor. So there's pros and cons and nuances to each method. This is just a depiction of a middle fossa.
Sorry, sir, to interrupt, but unfortunately,
Yes.
we're running short of time.
Yeah, we are. We're only 5 minutes. So, what should we finish? I think we can talk about this a little bit. House-Brackman grading. I'm sure all of you are aware of this. This is important in the setting of vestibular schwannomas. Post-operatively, if you have facial nerve paresis or paralysis, you should be able to categorize according to this. And there's varying degrees of recovery based on facial nerve, extent of facial nerve paresis. So usually a 2 or 3 is recoverable. But if you start getting to 4 and 5, the chances of recovery are lower. However, there's very good evidence to suggest that when you use facial nerve monitor and you, at the end of the operation, if you get 300 microvolt response at 0.3 milliamps, the chance of a complete or at least a House-Brackman 2 facial nerve recovery at 1 year after surgery is as high as 95%. So that is an important nuance which can help. This is just another quick case of an 18-year-old boy with neurofibromatosis type 2, has bilateral vestibular schwannomas, has had multiple operations for meningiomas and other brain tumors. And in this case, chemotherapy with Avastin becomes a very good option. And you should avoid radiosurgery because you can induce tumor growth because of the underlying genetic disorder. Comparing gamma knife radiosurgery and microsurgery. So just the simple takeaway point, when you have Coos grade 1, Coos grade 2, radiosurgery is generally superior. Coos grade 3 and 4 long-term outcomes are better with surgery. Hearing preservation, regardless of you choose radiosurgery or microsurgery, hearing preservation long-term is low with any kind of vestibular schwannoma, except Coos grade 1's completely intracranial lesion.
So, neurofibromatosis type 2 I think that's a very different beast and should be discussed very separately from a bread and butter acoustic neuroma. क्योंकि उसके अंदर you're talking about sign language, you're talking about a lot of other things, and the role of radiosurgery is still there. I would क्योंकि उनमें tumors इतने ज़्यादा होते हैं कि it just becomes sometimes it is you don't have any other choice. So I wouldn't leave radiosurgery out completely, but it's just a very beast that probably needs another lecture by itself.
Absolutely. So the goals, and we'll wrap up with this, that when you're thinking of surgical resection, maximal safe resection with preservation of facial nerve function. That should be your goal. Large tumors, decompress the brainstem. Radiosurgery is preferable in older patients with smaller tumors, medical comorbidities, and then younger patients who have Coos grade 1 or 2 tumors. I think we'll end with this. Any questions?